So today we're going to talk about varicose veins and surgical treatment of varicose veins. Yesterday we talked about how to manage it conservatively. Again, to recap, conservative management, exercising, weight control, elevate your legs more often and wear support stockings, 20 to 30 millimeter mercury pressure ideally. If not that, 15 to 20s, and wear them as much as you can. On that note, you really don't need to wear compression stockings to bed because your legs are elevated. You really need to wear support stockings or compression stockings when you're sitting or standing for a long time, because that's when everything backs up on you. So that's conservative management. If that fails, or if you have wounds on your ankles from venous problems, so-called venous stasis ulcers, bleeding from varicose veins, recurrent cellulitis, phlebitis, which is a clotted superficial vein, then I think that's fair enough to go ahead and have an ablation procedure done on the saphenous vein. So remember, there's two venous systems. There's a deep venous system, which you don't want to touch for this problem, and then there's a superficial venous system, which is the lesser system. All the vein blood flow should always be going up in your legs. That's the job of veins. Arteries bring them down, veins take them back up again. You want the blood flow to get out of your legs. Now, like we talked about previously, most of the vein work is done by your deep vein system. That's the main one in your muscles that you never see. The problem vein usually is the superficial venous system, the greatest saphenous vein that goes from the groin crease all the way down to the inside part of the ankle. And then the less saphenous vein, which is less likely to be involved in this problem, but it extends from the back of the knee down to the outside part of the ankle. And there's connections between these systems. And so when we're treating the saphenous vein, we're essentially closing it. We're closing it to stop the blood flow from coming back down that vein. Now, normally, doesn't that vein have a good use? Yes, it normally does. That's the vein that takes blood flow up. In fact, that's usually the vein that's used when heart surgeons do heart bypasses, or we do low extremity bypasses for limb salvage, a topic I'll talk about later. So that's the vein that we usually use to do bypasses with if we need to do them. That's why you don't want to jump into surgical approaches for these veins, because you might need them somewhere down the line. Now, the number of bypass surgeries is probably going down because of the stents are so good for coronary bypass, for coronary disease, but still, that's the vein that we normally use. Nevertheless, if it's not doing its job, you get venous stasis changes, you get these ulcers and all that stuff, and symptoms, intractable symptoms. And so then consider a venous ablation procedure. What does that mean? That means that this vein, it's not doing its job. So it's hurting you rather than helping you. So the vein flow tends to go up your deep vein system, but part of it comes down the superficial system rather than going up again. And so ablating it means essentially shut that superficial venous system down because it's not working well. How did we do that years ago? We would do a greater saphenous vein stripping, which is a horrible procedure. I couldn't stand doing them, but I did a lot of them because I had a lot of patients with this problem. So the saphenous vein stripping is where we took somebody to surgery. We'd make an incision in your groin, an incision in your ankle, put a little acorn structure through that vein and essentially rip it out. So brutal operation, a lot of bruising, a lot of discoloration, a lot of discomfort, pain afterwards. It took about 6 weeks to get over it. So much more elegant way of doing it is just essentially doing the same thing, but really not ripping the vein out. We leave the vein in place. We just shut it down from the inside with either laser fiber or radio frequency fiber or a glue. To essentially what we're doing is closing that system down that's not working well, so that the blood flow doesn't come back down again when you sit or stand for a long time. And that's how it helps with your symptoms. So we just do it through a little nick in your skin, a millimeter or two. We thread if it's a laser fiber up there, radio frequency fiber, these are just millimeter two size structures. We put it up to where the problem starts, which is right at the groin crease area. And then we do what's called tumescent anesthesia. The inside of the vein doesn't have really any sensation, the outside part does. And so we just put numbing solution along the length of that under ultrasound guidance, and then essentially withdraw that laser or that radio frequency fiber. And what it does is for lack of a better terminology, it welds the vein shut from the inside. Somebody described it as lighting a match inside the vein. That's a little exaggerated, but essentially it welds the vein shut from the inside to stop the blood flow from coming back down again. So the deep vein blood flow, the main vein channel, as you remember, goes up the correct way rather than part of it coming down your superficial vein system. Really elegant way of doing things. The recovery is very quick. I prefer the radio frequency. A lot of people use the laser. I think my personal anecdotal experience, people have less discomfort with radio frequency, although, I mean, plenty of people use the laser fine. The laser is just a hotter structure. The radio frequency fiber is at 119, 120 degrees, whereas laser can be much hotter than that. So I think you get less pain with the radio frequency, although, again, a lot of people use the laser and have great results with it. And then the other way is the glue. So there's a glue that you can, again, under ultrasonic guidance, push into the vein sequentially and essentially shut the system down from the inside. So these fibers are taken out of the vein. They just kind of sequentially withdrawn so that it closes the system down. The whole process takes about an hour at the most. Recovery is very quick. There's really not a bunch of pain with it. I tell patients, you may feel uncomfortable for a week or two. You may feel like you pulled your muscle for a week or two, but you really shouldn't have a lot of pain from it. And then we'll see them back within a week, ultrasound, and make sure everything looks good, because you want to make sure there's no potential complications like a deep vein thrombosis. Does this process extend to the deep vein system and cause a DVT? The incidence of that is very low, but we still check people within a week with ultrasound to make sure. And then in terms of recovery, once you get over the discomfort of the procedure, you can kind of go back to normal. So it's not a real painful procedure to go through. It works great. The problem with the procedure is that it doesn't mean that you're not going to get more vein problems in the future. And that's what I always counsel patients. Look, yeah, you're going to look great afterwards. Everything, we'll get about 70, 80+% clearance of your varicose veins. But don't think you're not going to get more veins somewhere down the line. Maybe 5, 10 years down the line, you will get some more varicose veins. They may not be as severe as the veins you have right now, but you're going to get some more somewhere down the line. Why? Because that's the nature of venous problems. Because remember, there's a deep vein system that can have valve problems too. And so you can expect some more, especially if you have a strong family history of vein problems, or if you're up on your feet a lot during your work hours. So those are things to consider. And in the long run, it's still good to wear support stockings and to exercise and be careful about your weight. Prevention is the key, though. If you have a strong family history of vein problems, particularly women, when you get pregnant, wear support stockings, knee-high support stockings. If you have twins, you're more likely to get varicose veins, so wear support stockings during that time. So complications of ablation of the saphenous vein, which is essentially shutting the saphenous vein down. You can get some swelling, not unusual, some bruising, not unusual at all, usually goes away with time. If you can sometimes, depending on how low you stick to get the vein, usually you want to go down as low as where the problem ends. The problem starts at the groin crease, it usually ends mid-calf or lower. You want to go down to that point, because if you just go from the knee above and you leave a segment of that vein below your knee that's not working well, you'll get more rapid recurrent varicose veins. And so you want to treat to the point where it ends. And then the lower down you go, the more you tend to get what's called neuropraxia. There's a saphenous nerve that travels right with that vein, and it doesn't like it when you muck with its friend, the vein. And so you can get neuropraxia, which is like a temporary damage to that nerve from the laser or the radio frequency fiber that causes an irritation. Sometimes you get tingling and numbness, kind of an unpleasant feeling from that stick site down to the ankle. That's one of the things we see the lower down we go. What are the other complications? Well, DVT. You can get a DVT from this. That's a deep vein thrombosis. The incidence is actually very low, but that's one of the potential complications of the procedure. Infections, bleeding, pretty unusual, unless you're diabetic and don't know about it. So that's the saphenous vein ablation. We can also do the lesser saphenous vein ablation, where we treat the back of the leg vein. The lesser saphenous vein, remember, goes from the back of the knee down to the outside part of the ankle. We'll sometimes treat that vein. We'll do what's called a phlebectomy, where we just make little stab incisions and take out branches of the vein. I often do that at the same time as I do a saphenous vein ablation because I think it just looks nicer. Some of the veins will go away by themselves, but I just think it looks better to do it that way. Be aware your insurance company may not approve that saphenous vein phlebectomy. I just do them even if they don't approve it, because I just, it doesn't make sense to me for you to come back for another procedure afterwards. So, and then if there's an accessory saphenous vein or an anterolateral branch of the saphenous vein, I'll treat that at the same time if I feel it's significant. That's where people try and divide these procedures up to 3, 4 procedures. I'm not comfortable with that. We can also do perforator vein injections or treatments with laser. Perforator veins, as you remember, are the connection between the deep and superficial venous system. We'll sometimes treat those depending on the anatomy and the physiology. But essentially, that's ablation of the saphenous vein system in a nutshell. It works very nicely. The results are usually very good. The issues in the long run are you going to get more varicose veins in the future? And if somebody tells you you're not going to get recurrent varicose veins or any veins after the ablation procedure, I would really question that answer, because you will. Tomorrow we'll talk about sclerotherapy for spider veins. Pretty short discussion. I may actually do it later today. And then we'll kind of progress on to deep venous system problems and try and kind of close out vein issues. And then we'll go to the other topics that I'd like to discuss, like carotid artery disease and aneurysms and things like that. Thank you. If you want me to talk about any particular topic, and send me a message, and I will prioritize that. But again, I can't give you specific advice about your issue because of this medical legal crap that I have to deal with. But I can at least give you some, background information that I think will be unbiased.